All right, let's talk about one of the most critical emergencies you'll face, an acute upper GI bleed. In these situations, every single second is precious, and what you do first, well, it changes everything. Let's get right into it. So picture this. A patient hits the door, and you suspect a major upper GI bleed. The clock is officially ticking. Your actions over the next few minutes could literally be the difference between a good outcome and a bad one. So what's the game plan? Okay, before you can jump into action, you have to think. What is the most likely culprit here? Because your initial hunch is going to guide your entire approach. There are 4 big ones that should be right at the top of your list. Number 1, and the most common cause by far, is peptic ulcer disease. Then you've got esophagogastric varices. These are often the most dangerous, a real hallmark of advanced liver disease. Less often you might see bleeding from a tumor, or maybe a Mallory-Weiss tear, from really forceful vomiting. Figuring out which one is likely is absolutely key. With those possible causes swirling in your head, your next immediate priority is figuring out just how bad this is. How much blood has this patient actually lost? Their vital signs are going to tell you the whole story. Your first clue is that heart rate. If it's fast, tachycardia, and you see orthostatic changes, or their blood pressure drops when they sit up, you know you're dealing with at least moderate blood loss. But if you see straight-up hypotension, that's a life-threatening bleed. The real takeaway here is you've got to act before that blood pressure tanks. Okay, you've sized up the situation. Now it's time to intervene. The stabilization protocol kicks off with a few non-negotiable actions that have to happen right now, all at once. So here are your first 3 moves. 1, make the patient NPO, nothing by mouth. They're likely heading for an endoscopy. 2, get that IV access. This is your lifeline for resuscitation. And 3, get them on a monitor immediately. Vitals, cardiac rhythm, urine output. You need to track their response to everything you're doing. And when we say IV access, we mean business. We're talking 2 large bore IVs. That means 16 gauge or bigger. This is so critical because you need that high flow access to push fluids and blood products in fast. This isn't just a nice to have, it's essential. So, the big question, when do you actually pull the trigger on a transfusion? Well, it's not based on some magic number. It's all about specific, evidence-based hemoglobin levels that actually change depending on the patient's condition. Look at how we tailor this. If a patient is having a heart attack, acute coronary syndrome, we transfuse at a much higher hemoglobin, less than 9 or 10, to protect that heart muscle. For someone with stable heart disease, the trigger is a little lower, less than 8. And for pretty much everyone else, it's a hemoglobin below 7. Sticking to these guidelines is crucial to avoid giving too little or too much blood. And hey, it's not just about red blood cells. Don't forget the platelets. A patient can't form a clot if their platelets are in the basement. So if that count drops below 50,000, you've got to give platelets to help stop the bleeding at the source. While you're getting them stabilized with all those fluids and blood products, you can also build a pharmacological bridge to the definitive treatment, which is usually going to be that endoscopy. There are meds that can help you get this bleed under control right now. For almost any severe upper GI bleed, you're going to empirically start a proton pump inhibitor, or PPI. A big 80 milligram IV dose of esomeprazole or pantoprazole is the way to go. It cuts down on stomach acid, which makes the environment in there much better for a clot to form and stay stable. Now, if you've got that gut feeling that you're dealing with varices, especially if you know the patient has liver disease, you're going to add another medication to the mix. A 50 microgram IV bolus of octreotide. This stuff helps reduce blood flow to the gut, which lowers the pressure in those bleeding varices. So let's recap. You've assessed the patient, you've started stabilization, and you've initiated medical therapy. You've bought precious time. But you have to remember, this isn't the end of the road, not even close. It's just the beginning. Your definitive next step is getting gastroenterology on the phone for an urgent endoscopy. Your rapid actions have handed them a stable patient, giving them the best possible shot at a successful outcome.